Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.
Welcome back to Pod Patrol with your host, Dr. Jeff Dikis.
And Dr. Leland Jaffe.
How's it going, Leland?
Good. How are you?
Good. You guys just had the match, in your job. I have students with me, so I'm affected a little bit by the match, but you're really affected by the match. So
yeah,
how'd that go?
It was good. Match day is for me probably more, if not more, as exciting or more exciting than graduation. It's one of these days that really, it obviously identifies where you're going to be for the next 3 years for your training. So it's an exciting day, on campus for sure. In my office, one of my roles being the Associate Dean of Clerkship and Residency Placement. So I spend a lot of my time with our upperclassmen trying to help them transition into externships, but then into residency as well too. So it's definitely a big part of what I do. Sure. Great time. Yeah. What about you guys?
Well, I was just going to say that, when you go through the match process, it's a surprise. You don't know what's going to happen. Graduation, I'm going to graduate.
Exactly.
It's exciting, but it's kind of like a foregone conclusion. When you match, it's like, drum roll, please. And you're kind of like, oh my gosh. When we did it, I don't know how you do it. I think you did like envelopes or something. But when we did it, we would just click. And we would, Ashley and I would sit there together, and she had hers open and I had mine open, and it was like, click. It's like, this click is going to determine maybe the rest of my life, but certainly the next 3 years of my life.
Oh, absolutely.
Before I make this click, it's going to, it changes my life forever. So,
absolutely.
It's pretty exciting.
Yeah, it is fun. It's we do envelopes, and we had a match day party on campus where all of our class of 24 students, as well as family and some friends and significant others, attended. So we probably had a room packed full of at least a couple hundred people. So it was a lot of fun. It's funny though, because we do a countdown, and before the countdown, myself and our dean gave a few words to the students. And when we do a countdown, I always think of a countdown like on New Year's Eve, right? 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. And then you celebrate right at the 0. But this countdown is kind of funny because you get to 0, and then it's a few moments of silence where people open their envelopes, take a few moments to process where they're going, and then there's a celebration afterwards. So it's always kind of an interesting experience.
Yeah, I bet. That is interesting. One thing I noticed, at least on social media, was that an uncanny number of people got their number one residency. It was funny. I never saw anyone say, oh, I got my 12th pick. Right? And almost a physically impossible number of residents got their first choice. So good for them. I hope that is the case, and I hope they're happy with where they're going to be. But I just thought it was funny. It was like, wow, everyone got their first choice. This is amazing.
Yeah. No, absolutely. I think hopefully you're not going to disclose if it's your 12th pick, but no, it was fun. It was fun. We had a good time. Giving a speech to the students is kind of an interesting experience for me because I'm a teacher. I lecture and run classes and workshops on a weekly basis. So I'm very comfortable speaking in front of an audience. But whenever I have family there, friends and family, I always feel like I need to gather my thoughts. And, this time I actually wrote out a speech and probably about a couple minutes ahead of time, I just basically crumbled it up and threw it away. I'm like, I cannot read a speech. I just got to really speak from what I'm feeling at the time. So it was a good time. I think, seeing some of the students, their visceral reactions of excitement and just being overjoyed was, makes it all worth it in terms of the ups and downs and challenges and all the all the hard work put on over the last 4 years.
Yeah, for sure. I don't know if you're like me, but I still don't feel like an adult. I know I am. I'm almost 40, but I still don't feel. I'm like, I'm in a room and I'm like, why would these adults want to hear what this kid has to say? And then I'm like, wait, no, I guess I am an adult. Like, okay, well, moving on.
Yeah, no, for sure.
It doesn't sink in yet.
Yeah.
Maybe it's because I'm so immature.
No comment.
I act like I'm 22, so I'll be perpetually 22. That's okay.
It's a state of mind.
Yeah.
No, I think
when you feel young.
Yeah.
Your back starts to hurt more when you get out of bed, though.
Oh yeah.
You don't feel 22 anymore.
Yeah, I don't know if I said this before, but yeah, I mean, working at a college, same with you, is difficult because we get older and they stay the same age.
I get older, they stay the same age.
Yes, and so your jokes get less funny. What you reference becomes less and less relevant.
That's what I was gonna say. My Dumb and Dumber references are falling on deaf ears. My Tommy Boy and Happy Gilmore references are just crickets, and I'm like,
I made a Doogie Howser comment in class one day, and nobody knew who he was.
Yeah,
it's like what?
Yeah, my wife does that with her lectures. She puts a lot of like Office quotes in there, and I think Office had a little bit of a comeback with Netflix. Most of these kids weren't watching it when it was on the actual television.
Yeah,
it was on Netflix, so they get some of those, but a lot of her references fall a little bit flat.
Yeah, one of my this is a few years ago, but we would do these in-person board review courses, and sometimes I'm asked to review 2 courses in 30 minutes, right? So really have to go through high yield information really quickly. And after 30 minutes of just rambling through 150 slides, I made a comment that I felt like I don't know if you remember, but the commercials for the Micro Machine commercials where it was a guy that just spoke incredibly fast.
Oh, yeah.
This is the Micro Machine Man presenting the most midget miniature motorcade of Micro Machines. Each one has dramatic details, terrific trim, precision paint jobs, plus incredible Micro Machine pocket play sets. There's a police station, fire station, restaurant, service station, and more.
Yes.
So like that's how I felt for 30 minutes, and I made that comment afterwards, and everyone's like, "What are you talking about? Micro Machines? What?" Yeah. I'm like, "Oh gosh, I gotta stop talking about these things."
It's a different generation, and it's only going to get worse too. They're only going to get less of your references as time goes on.
Yeah, that's okay.
So we thought this episode would be fun to do a mailbag episode. I think you and I, being in the positions that we are, being around lots of students, we get a lot of questions. And so instead of answering those one-on-one, which I think you and I are both happy to do, we thought we'd do a mailbag episode where we kind of display those questions that most people have. It's kind of like when you're in class and you have a question, but you don't want to raise your hand and let everyone else know that you don't know.
Right.
But then someone else raises their hand. You're like, yeah, I have that question too. Right. And then you realize everyone had that same question. So one of those deals where everyone probably has the same question. So hopefully this will be helpful for I imagine most people listening.
Maybe one of the questions a lot of people have is why there's a bat over my right shoulder.
Question number 1.
That's right.
Are you Batman?
My youngest daughter has been obsessed with bats since she was 1 or 2 years old. So we have a lot of bat. I don't know if it's memorabilia is the right word, but a lot of bat decorations around the house.
That's awesome.
It's always Halloween at our house.
That's great. Have you ever been to Austin, Texas with the flight of the bats? Do you know about this? Where they live under the bridge and then they leave at dusk every night? It's amazing.
Yeah, I was there. I didn't see it. I was there for ACFAS was there a few years ago, but it was too early in the season. I think it was February when the conference was, but I think the bats didn't start until a couple months later.
Okay.
But definitely on our bucket list.
Yeah, if anyone's a bat fan, check out Austin, Texas. All right, so this is Pod Patrol Mailbag. Let's just jump right into it here. So question 1, this is a common question because it affects everyone. What is the best job for a podiatrist? What do you think?
Yeah, a lot to unpack with one simple question here because I don't think there's a one size fits all with this question. And it really, there's so many factors to consider what's the best job in regards to the individual. Are you interested in traumatology? Are you interested in being in an academic center? Are you interested in being rural, urban? I mean, there's so many things to unpack here that, we can almost spend an entire episode just talking about this in general. But, for me, and I can only talk about myself and my own experiences. When I first started, I thought private practice was the way for me. The reason being is I wanted to have autonomy in my decision making. Here's a few examples. So when I first started practice, I was in a 2-person practice, and when you only have 2 people essentially making the decisions, it's a lot easier to instill change. For example, after a couple of years into practice, I found myself being involved more and more with hospital-based wound care, and then these patients would come to my clinic, and it just felt weird having a nice, clean, elective bunion surgery in the same chair, followed by an infected gangrenous IND, right? And so,
Agreed, yep.
so I'm like, okay, I need to get on a wound care panel. And so I was able to be invited to work in 2 different wound care panels in Missouri when I was working in St. Louis. And all I had to do was get the approval of one other person. Versus now
right.
being in an academic institution, to actually get change there's a lot more layers to go through to try to establish some type of change like that.
Makes sense. So I think between the two of us, you started in private practice and moved to academic medicine.
Right.
I started in an orthopedic group and moved to a multi-specialty group. So between the two of us, we have experience in 4 of these different models. I could only speak to and my wife, I guess, moved from orthopedic group to academic medicine as well. So kind of crossing between both of what you and I have experienced. So I could only speak to my experience, but I thought both jobs were great. The orthopedic setting and the multi-specialty group. One of the biggest issues that I found, and keep in mind, these are all personal experiences. Everyone that gets out into the real world, your experiences are going to vary. So that being said, in the orthopedic group that I was in, there was a multi-specialty group in that same town. And if you think about it, when you work for a multi-specialty group, they have a lot of family practice doctors, and they are going to refer to the specialists in their same multi-specialty clinic. So I went up against that in my first job, trying to get referrals. And I walk into all these doctors' offices and I say, "Hey, I'm new in town. Here's where I trained. Here's what I can do. Nice to meet you. Keep us in mind." And they were never going to send me any patients because there's no incentive for them to do that. When they send referral to their own multi-specialty group, and then that doctor orders MRIs, x-rays, goes to their surgery center, that benefits their group. So they're basically incentivized to keep those patients within their same group. And now selfishly, I'm on the other side of that. I'm in a multi-specialty group. I'm benefiting from these referral patterns. I'm benefiting from keeping these patients in the same group. So something to keep in mind, again, that does not affect everyone, but something to keep in mind as one kind of small but unforeseen difference between those two groups, jobs.
Yeah, and I think one thing to keep in mind for those that aren't too aware of the practices within these types of groups is the doctors will get dinged if they refer outside of the group, right? So if they do that enough times and there's a pattern, they're going to hear about it. So they're definitely incentivized to keep their referral base within their network.
Yeah, for sure. So I don't have a whole lot of experience with hospital-based employees as far as podiatrist goes. I have a few friends that are hospital-based employees, and they like it. They seem to enjoy that. To me, there's a lot of bureaucracy that goes along with that. There's a lot of overhead. I shouldn't use overhead. I should say oversight. There's a lot of people above you that tell you what we can and can't do.
Right.
So that being said, though, I think that if you get into the right situation with a good RVU contract, it can be very lucrative. A lot of the residency directors, they're all hospital-based. Not all, I shouldn't say that, but some of them are hospital employees that work for the residency as the director. So those can be lucrative jobs as well, but the downside of that being the potential bureaucracy over your head of micromanaging you when you just kind of want to do what you want to be able to do. And on the complete flip side of that is private practice. If you're opening up shop by yourself, there's no one telling you what to do.
Yeah.
Right?
And I think that's what you have to decide. Do you want to be the boss? Do you want to make all the decisions, or do you want to be an employee, right? Where you report to somebody. And I think those are 2 very different mindsets. When I was in private practice, I was essentially being groomed to take over the practice. And I realized that, it's kind of funny because a lot of people, when I left that situation, were very surprised because, number one, I was busy. I was getting a lot of surgical cases. I had a pretty good referral base. And let me tell you, leaving a practice was a lot harder than building a practice. So it was really difficult to leave. So, um, so the what I'm trying to get at is I realized that I'm not business savvy. I didn't really have that skill set, and I really wanted to be more involved with the residency program in St. Louis. But unfortunately, there wasn't a pathway for me to get there, and that's really why I moved into this academic role when I had the opportunity to move into that. Being in the academic medicine side of things now, again, we all report to somebody, and so you are an employee of the university. So again, it does change in terms of some of that autonomy and making that decision-making process. So being in private practice, you definitely have the most freedom to make your own independent decisions. But, again, you have to be more entrepreneurial minded and business minded. And, that's a different skill set that some people have and some people don't have.
Yeah, I agree. And one other thing to think about, I always tell the students, because they always ask me what it's like working for a multi-specialty group. One of the differences between that and private practice is that when I show up, if the internet's not working, it's not my problem. If the lights aren't on and we're on backup generator, that's not my problem. If the EMR is not working, that's not up to me. Someone else on a team of IT and the, people that work in the building and all those things. I'm not worrying about, the guy that shovels the driveway didn't show up today. I'm not worrying about any of those things. So it takes a lot of the headache. Now, you pay for those things, right? It's called overhead. So you're not getting all those things for free,
right?
Nor should you expect to. But in private practice, you can maybe control those costs a little differently because maybe you're the one that's taking care of that. Maybe you're the one that's calling the internet service provider and saying, hey, is there an outage? We got to get this up and rolling. I got patients coming in the door soon. So yeah, I think all of these provide a very different experience. And sometimes you don't know what you like until you are part of it. So I think when you're in school, when you're in residency, rotating through with a lot of different variety and getting exposed to these is the most beneficial.
Yeah. And the last thing I'll say, and I think we said this on an earlier episode, but I'll repeat it, is many of us, including you and me and Ashley, like we all are in our second job. So we're not in the first job outside of residency. So I think a lot of graduating residents or fellows put so much pressure on themselves to figure out the perfect situation where they're going to be for the next 30, 40 years or whatnot. So, and that's not usually the case. In fact, most of my constituents, the people I graduated with, are not in their first job, right? A lot of these individuals moved to a different situation because they learned that their skill set isn't so much with private practice, but maybe with more academic medicine, or maybe they want to be more of an employee of a group versus more independently owned. So you might not know those things until you're actually in that situation. So I guess what I'm trying to say is don't put so much pressure to find that perfect job right out of residency that you are going to absolutely be with forever. It might not be the case.
I agree. And some of these job opportunity types are going to be driven by location. If you want to teach at one of the schools, well, you're limited to, I don't even know how many schools there are now, 9, 10,
11.
Whatever there are, 11 schools. You're limited to 11 cities in America, right? And so that may not be in the cards for you. Does your town have a multi-specialty group? Maybe yes, maybe no. Do they have a prominent orthopedic group? Maybe yes, maybe no. So some of these are going to be location-based too. I think a lot of people have an idea of where they would want to live and therefore want to practice. And sometimes the best job in location A is not the best job in location B. So I think the end result of all of this is that they could all be good jobs and keep an open mind.
Absolutely.
Next question. Ooh, this one's going to be tough for us. So
that's a spicy one.
What's the best residency? What is the best residency? So, I think the answer to this is it depends. It depends on every person. The best residency for me is not the best residency for you, and vice versa. What do you think?
Yeah. Difficult question to answer, especially without making some people angry out there.
Right.
However, what's great about podiatric residencies in 2024 is that a majority of the residencies are 36 months. There's a couple that are 48 months, and just a couple I think that are left in terms of being 24 months. I don't think there's too many left at this point. But the standardization of training is continually, I think, moving towards parity amongst programs, generally speaking. Having said that, you again, similar to the discussion on the what's the best job situation for each individual, this one also depends. And some of the things to consider regarding residency are, what does the residency focus on? Do they have a lot of traumatology? Do they have pediatrics? Do they do congenital deformities? Do they do, fill in the blank, sports medicine? Right? Because each residency does, while they do have to hit a minimal activity volume to be credentialed by CPME, they still can focus on one particular niche within foot and ankle surgery, right? So that's something to look into. The other thing to think about too, and for me in hindsight, certainly being 2020, is I went to a big residency. I had 5 residents per year. So we had 15 total residents. And in hindsight, for me, I'm a little, people don't believe me when I tell them I'm a little bit more of an introvert than an extrovert. I fake it really well, especially when I need to. But I'm never the loudest person in the room, and I can definitely be overtaken by bigger personalities. And so I might have thrived a little bit better in maybe a 6 or 9 person residency versus a 15 one. So I think that's also something to think about in terms of where you might thrive more in that smaller family like feel, or a big dysfunctional family, if you will.
Yeah. In residency, we had 6 per year, so we had 18 plus a fellow. So we had all kinds of people, and we ended up getting along. So that was why picking our incoming residents was so important, to make sure that we all vibe and we all get along.
Right.
But yeah, I think that's a big determining factor. Now, if you're tuning in and you want to hear, no, I want you to tell us the best residencies. Well, I think that's tough. Back when I was in residency, I could rattle off UPMC, West Penn, Inova, Swedish, Presby St. Luke's, right? But back then, Wake Forest didn't exist. The upcoming program in West Virginia didn't exist. All of these programs are bound to change with time. So keep that in mind when you're asking someone who's 55 years old what the best residency is. They're going to tell you something completely different than me or you or someone else who just went through their rotations and goes to that residency and says, I don't know why they said that was the best, because that was horrible, right? And vice versa. No, they said that was a bad one, but I loved it there. So
right.
I think ultimately you keep an open mind. And if you do have questions about what are generally thought of as the actual best residencies, I think people like you, Leland, at the school are the best resources.
Yeah. And what I would recommend doing is never taking advice from somebody who either didn't rotate or attend that residency. If they start out with, I heard from somebody that this is true, it's usually not true. So keep that in mind. If you want to learn more about these programs, AACPM.org has a tab under Casper CRIP where you can read about the different programs and what they offer. You can sometimes even go to their websites and find more information. For me, in my experience, how I ended up doing my rankings, it really boiled down to, I rotated primarily in the Midwest. And when I was rotating, I remember one program where I ended up eventually going, where I was in a case, and at the end of the case, I remember thanking the attending for, letting me participate in the surgical case. And he told me something along the lines of, oh, I'm not the attending, I'm a 3rd-year resident. I was like, wow, that's really impressive. And he functioned really well at a attendings level. I'm like, that's what I want to be. So that did it for me. I'm like, that's what I want to be. This is the product of this particular program and what they're training. That's how I want to be. And that kind of sealed the deal for me.
Yeah, I agree. I went to programs where I never saw any of the residents doing the surgery. And I saw programs where the attending was in the room, but the third year is teaching the first year how to do it. And that's a very different feeling to me. If the third year feels so comfortable that I've done enough of these, I don't need this. Here, let me show you how to do it. Number one, they've already done it enough. Number two, they've done it enough to be able to teach it. That's a huge difference to me. So those are some things to look for, certainly when you're out on externships.
Another thing to look at too, just to not to beat this point too much, but does your program allow the residents to follow up with their own work? And to take that even further, are the residents involved in the preoperative workup and decision making in what procedures are being done? Because I think there's a lot of programs where the resident might be assigned the night before and they don't know anything about the patient, right? Or any of the decision making that went on. They probably didn't even see any films or imaging until maybe in pre-op, if they're lucky. And they're just kind of going through the technical aspects of doing a case without much of the decision making. So I always try to look for that too. Are the residents involved in that decision making process, and are they dealing with those complications afterwards and how to manage that? Because you might be surprised to learn that a lot of residents aren't involved in either the pre or the post-operative care of some of these cases.
Yeah, I think that's hard because that is pretty much what you're going to be doing when you're an attending, right? You can't just show up and do surgery. You have to see the patient and work them up, choose the proper, procedures to perform, and be able to back that up. Maybe if things don't go perfectly, hey, we talked this through. Remember, there's a slight risk for non-union or XYZ, and being able to manage those post-operative complications. So
did I tell you about one of my first cases as an attending?
With the horse?
Yes, yeah, exactly. So that's again, for those that didn't hear that earlier episode, one of my first cases was a lapidus fusion, and post-op week 1 or 2, a horse stepped on the cam boot and just completely disrupted the fixation. So that was kind of my introduction into post-operative complications, and I was like, very stressful.
Here we go.
Yep, exactly.
That's awesome. Yeah. All right. So anything else to add on the best residency? I mean, I think that's going to be variable. We're not copping out here. If you come to me and you say, hey, what are the best residencies? I'll tell you what I think are the best residencies. But I don't think that's fair because I haven't been on externships in years and years and years. So what I would say is one kind of little cheat code. My kids are young and they're into video games and they talk about OP and cheats and glitches and all these things. Anyways, one little cheat code is to pay attention to the students the year above you. Where did they rotate? Oh, well, the number 1, number 2, number 3, number 4 people, they rotated through these programs and they matched at this program. That is just kind of like a little peek into maybe what some of the better residencies are.
Right. And if anyone has any questions, you can email and reach out to me. I'm happy to help in your decision-making process. But this is one of those questions where I'm probably going to answer your question with a question. So don't be surprised if that's indeed, if you do reach out to me, there are some things I would need to know to really help guide that decision-making process.
So I guess what we're saying is the best residency is UPMC.
Yeah, that's right.
Next question.
That's right.
All right. Next question. How do you prepare for surgery during externships? So when you go out on externships, you're going to be assigned. I can only speak to the externships that I went on, but You're going to be assigned with the way that we did it in my residency was you were with one attending for a week. You're 4 different weeks, one with each. So you kind of spent a little bit of time with them leading up to surgery so you could find out, okay, tomorrow we have this, this, and this. And so what are the tips for them to prepare for surgery when they're out on externships? What do you think?
Yep. So I think every attending is going to have a different level of expectations for the students, but there are some pieces of information that there's no excuse for not knowing. And it all starts, number 1, with the anatomy, right? We all know that every student takes a detailed lower extremity anatomy course, and you should know your anatomy, right? So that's number 1. If I'm going in there and I know I'm doing, let's say, a tibial nerve release, and we're going to be making an incision over the tarsal tunnel, I better know the layers of tissue and the anatomical structures, and even the cross-sectional anatomy in that area. That's a very fair question to present to a student, the anatomy. So always know the anatomy, always know the information that you should be able to learn in the classroom. Having said that, I do understand, like, when students rotate with me in the operating room, and we do bring some students in the OR with me. Some are as early as second year students. But again, I always expect they'll know their anatomy, but I do want them to come prepared, right? So you do want to try to read up on these cases. And I think there's some surgical textbooks that do provide a step-by-step approach on how to do certain cases. So I think surgical textbooks are one, and we can get into that in a moment. The other thing too is to know what you're doing, right? So you could ask the residents, what type of fixation are we going to be doing? And maybe you're going to be doing, first thing that comes to my mind is we're going to be doing a tibio-talocalcaneal fusion with an intermedullary nail, right? I might find out what nail are we using. You can go on to their website and look at the surgical guide on how to do the steps of this procedure, right? There's certain things that you can look up ahead of time to come as prepared as possible.
Yeah, I think that's good. I think it's easier now than ever to be well prepared, whether it's textbooks or just Googling a procedure and watching a video on YouTube, or,
right,
looking at some of the stuff that I post on my Instagram of cases, and I try to kind of walk people through the thinking behind it. So there's so many resources for people to be well prepared that I don't think there's any excuse to not be well prepared. Now, will you get every question right if they ask you X, Y, or Z? No, that's not what we're talking about. We're talking about, did you prepare? Did you look ahead? Did you understand what we're going to be doing today?
Yeah, I agree. And you can even look up on websites. There's an AO North America that can talk you through pretty standard fixation techniques for really all different foot and ankle related surgical cases. But yeah, no, I mean, I don't remember. I know YouTube was around when I was an extern, I think, but I don't remember, having access to video unless it was produced by one of the attendings or given to us ahead of time.
Yeah.
I do remember, one of the surgical textbooks that I use would be the Coughlin and Mann foot and ankle series, and they do have CDs. I know that really were good.
CDs. What's a CD?
Exactly. Well,
how old are you?
Compact discs.
What do you do with this thing?
Yeah, not a certificate of deposit. It's funny, some patients bring me a CD on an MRI, or an MRI on a CD, I should say, and we don't have I didn't have a CD-ROM in my clinic the other day. I couldn't even look at it.
That's awesome.
Yeah.
What do I do with it? It's like Zoolander. Yeah. It's in the computer.
Did you find the files?
I don't even know what they look. What do they look like?
They're in the computer.
They're in the computer?
Must be an on button somewhere. Press the Apple thing.
That's awesome. Yes. So, yeah,
so I think, Coughlin and Mann, McGlamory, Chang. Those are three kind of classic. One that I've used, I don't know how to pronounce it, so if you are this person, forgive me, but it's spelled Kitaoka, like Kitawaka, something like that. And it is one of my favorite books. I still have it around here somewhere, and still, if I'm doing something I haven't done in a while, I'll flip it open and be like, okay, all right, 1.5 cc's. Okay, take a wedge that's no bigger than 1 centimeter.
Exactly.
These little things that are kind of like little pearls and things, like, okay, I know how to do the procedure, but I'm gonna encounter, okay, I need to watch out for this. That makes sense. So still, I mean, preparing for surgery, you shouldn't ever stop preparing for surgery. So
no,
I still
and one
use
thing
those textbooks.
Yeah, one thing I'd like to add to this slide, and not to just be focused on surgery, is when you're on externships, when you're trying to look up any type of medical information, if you're medically managing patients, you should have access to their medical library, or at least the library at your university. So I still to this day go on up to date all the time, trying to read up on patients' conditions and how to manage it. Don't forget, read your literature, right? Look up in the peer-reviewed literature that that you have access to also through your libraries. I had in my lab coat the pocket medicine from UMass General. That was really a good, for me, resource for internal medicine when you're rotating and managing inpatients, right?
Yeah.
So, don't forget about the medical management as well too. So those are some of the resources that I would use on rotations when I'm trying to, update my knowledge on some of these medical conditions I'm just not too familiar with, and I still will to this day.
Yeah, I think those pocket guides are good to kind of always have around. So we'll put a plug in for some of those pocket guides. Not any one in particular, just find one that you like and use that.
Exactly.
What is a fair salary for a new graduate? So we've touched on this a little bit in some earlier episodes. We pulled up the U.S. News World Report, ranges from 97 to 210. I don't remember what it said, honestly.
Right.
So I don't know. What do you think is a fair salary for a new graduate? It's going to be a range. It's going to be based on geography. It's going to be based on, orthopedic group or private practice or 10 different things. But what do you think is fair?
Yeah. It's hard to put a numerical value on that, to be honest with you. But if I'm a new graduate and this is my first job outside of residency, I'm thinking if I had to put a number on it, I'd say in the mid 100s.
Yeah,
is probably fair.
Yeah.
Kind of the rookie salary.
What's that? The
rookie salary, out of your rookie contract.
Do I get a signing bonus?
That's right. But
no,
keep in mind, this is going to grow each year, especially once you can demonstrate your value and your productivity. It's a much easier bargaining chip when you can show your how productive you are, right? Because right now everything is really just hypothetical in terms of what you can bring to the table when you can produce. But I think somewhere in that range is a real fair starting point.
I think it's tough when you start because when you're first getting started, depends on the job, but you may not have as big of a population or patient base as you expect or as you want. So you want a larger base salary initially. Right. And then later, you actually might want a lower base salary with a higher bonus structure. So I told people previously in the last episode that we talked about salary, my first job was for 180 with a 50-50 bonus.
Okay.
After that, and then my current salary at my new job, my guarantee initially was 225 with a similar overhead structure in that, or actually I should say a different overhead structure in that my overhead was kind of more of a set fee, and then anything above and beyond that was kind of for me to keep. And the guy that had my job before me was making over 400.
Oh, wow.
So
yeah,
there's a lot of room and a lot of growth there. But to me, I think that keeping in mind salary isn't everything. I tell the students that you want a fair salary, you want a good salary, but to me, it's not worth it to be seeing 70 or more patients in a day. That's just a recipe for burnout. Yeah, you have a high salary, but how long is that sustainable for? So if you drew this out on a chart, and maybe I'll add this in as a graphic later, but if you drew this out on a chart, as your salary goes up, your happiness level goes up. And then at a point, your happiness level starts to go back down and your salary keeps going up, which means there's a point on that graph where you're at maximum happiness and maximum salary. And your salary might continue to go up 600, 800,000, $1 million. I know people who have made that much money, but their happiness level cannot be worth that amount of money. At least to me, the family life balance is just not worth that extra salary to me. So I just throw that in as kind of an aside that I always try to tell the students. If they tell you, hey, you're going to be making 600, well, that sounds great, but how nights, weekends, not seeing my family, what are we talking here? How am I going to justify that salary? So keep that in mind.
Yeah, I think it's a fair point. Because both of my jobs I've been salaried for the most part, so there really isn't too much fluctuation. But I think you're exactly right. I mean, I definitely value my time, and there's times of the year where obviously I'm kind of burning the candle on both ends, and it's incredibly busy. But for the most part, I'm home for dinner. I'm home on the weekends. I go to my kids' volleyball games. And there's value to that, right? Because as and we both have kids that are elementary age and such. Like those years go really quickly, and when they're gone, they're gone.
Right.
And keep in mind, when they get a little bit older and your kids become more independent, that's probably time where you can maybe ramp up your work productivity, because you're just not. It's kind of sad to say, but you're not as needed at home as much, in terms of raising young children. So I think there's a time and a place, but there's definitely value to. But I think it's funny, working with a lot of the Gen Z population. Like they definitely put a good value on personal time and happiness, right? So I think they may not have as much difficulty, identifying the value in self-care and taking care of your mental health, and not feeling like you have to put the throttle down full steam ahead at all times. So hopefully they find good balance.
Yeah, I think that's very important, avoiding burnout. So salary and burnout are probably closely related. If you wanted to plot the most closely related two things, it's going to be salary and burnout, because salary is usually a 1-to-1 relationship with how busy you are. And the way that medicine works, you're paid. Well, let me take that back, because the way that you're paid and the way that my wife are paid is not that way. You're more of a set base salary structure, as opposed to someone that's collections based like me. The more salary, yeah, great, but the more work it took to get that, the more likely to burn out, the more likely to have, mental health issues and all kinds of unforeseen circumstances that go along with that. I'm on the wellness committee at my job. So I am in charge of our wellness program, which is mostly targeted around mental health and awareness, and supplying resources to providers that are intended to prevent burnout, suicide, quitting the job, leaving the field of medicine, and all the things that come along with that. And so our company has lots of resources from an outside company, I shall say, that they pay for to provide these services, whether it be counseling. They have concierge services where you can call and they'll get you tickets to a ball game, or find someone to buy a present for your wife, right?
No kidding.
Yeah, because I don't know what she wants. How do I know?
I'm like, that could be helpful.
What does she want? I don't. Maybe you can call her and see. I don't know what she wants. So yeah, if someone can do that, that'd be great. But I mean, I think we're getting off topic here from a salary standpoint, but I think the end all takeaway is that higher salary is not always the best thing. So fairly compensated salary, fair compensation is what you're looking for.
Yep, absolutely.
So I think we'll leave it off there for this episode, unless there's anything that you want to add.
No, I mean, lot of good information, and certainly a lot of good things for the audience to consider when you're thinking about these particular topics. So again, if you have any questions about either of these or any of these topics, don't hesitate to reach out to either one of us, and we'd be happy to help you out.
Yeah, we're both available on Instagram. I'm FootDoc Duo, and you are
Leland _Jaffe DPM.
If you send us messages on there, which a lot of people do, actually, more than I thought they ever would, reach out to us on there, or you can reply to any of the videos that we post on YouTube, and we can reach out to you that way. So we are accessible, unless you have anything negative to say, and then keep it to yourself.
I can take it. Yeah,
I can take it too. If I can throw them out, I should be able to handle it. So yeah, that's fine.
Plus, we can always block you on Instagram too. So
that's an easy click. All right. Well, we'll leave it off there and pick it up next time. I'm sure there'll be lots more questions for us to answer in the future. So until next time on Pod Patrol, this is Dr. Jeff Dikis
and Dr. Leland Jaffe. We'll see you.
Bye.